Hello and welcome to this edition of Represent NYC on the Manhattan Neighborhood Network. I'm Councilmember Shaun Abreu. I represent District 7 in Upper Manhattan, which runs from Washington Heights down to the Upper West Side. I chair the City Council's Committee on State and Federal Legislation, and I am a member of the Committee on Mental Health, Disabilities, and Addiction. Today, we'll be talking about mental health. New York City has never had the full slate of mental health resources that our residents need. And the consequences of a weak mental health care system become most apparent whenever our city faces a crisis. For instance, at the peak of the COVID-19 pandemic, as school buildings closed and children faced an unprecedented level of social isolation, our youth struggled with depression. As our city's housing crisis was worsened and more families and individuals have found themselves without a stable place to live, more people are finding themselves in acute distress that affects their mental well-being. People of color and low-income New Yorkers especially often face difficulties getting help. This has a tragic impact on our communities, including alarming rates of suicide and substance use disorder. In the face of these challenges, I'm honored to introduce representatives from 3 groups doing life-changing work to provide mental health and substance use services in our community. Today, we're going to have a conversation about their work and the mental health landscape around New York. First, I'll begin with Alicia McFarlane, the Chief Legal and Chief Program Officer from Samaritan Daytop Village is with us. Hi, Alicia. Could you tell us a bit about the work that you do?
Hello, and first, thank you for this opportunity to speak with you on such critical issues. At Samaritan Daytop Village, we've been in existence for a little over 60 years. We're a nationally recognized human service organization with a full continuum of behavioral health services. We provide services to the entire state of New York. So we're located in 10 counties in over 60 programs. The majority of our programs are within the 5 boroughs. We provide substance use disorder treatment, mental health treatment, transitional and supportive permanent housing for singles and families, innovative therapeutic services to veterans, and we operate a senior center as well.
Well, thank you for that amazing intro. Next, we have Morgan Siegel, the Manager of Wellness Services for the Northern Manhattan Improvement Corporation. Welcome, Morgan. Same question. What kind of services does NIMIC offer?
Yeah, thank you so much for having us. From NIMIC, we're a community-based organization and we provide holistic wraparound services in Upper Manhattan and the Bronx. We provide services that range from housing, immigration, benefits, domestic violence, education and career services, food pantry, and mental health. Specifically within our mental health programming, I find it extremely important to provide trauma-informed, culturally responsive services in both Spanish and English. We currently provide assessment tools and then referrals into our mental health program, which is internal in our community-based organization. We provide individual, couples, and referrals for clients that might have a specialized need, and psychoeducation really to help to support clients to come to us who might have stigma or different beliefs around the mental health system in general. That's
a very great intro as well. And last but not least, we have Jenny Mariaschin, the Director of Behavioral Health Integration, joins us from Ryan Health. Good morning, Jenny. And I'll ask you the same to tell me a bit about the work done at Ryan Health.
So Ryan Health is a federally qualified health center, which means that we provide primary care services in areas in need, particularly of that type of service. We also have nutrition, we have women's health, we have behavioral health, and we also have an emotional wellness center for patients just from the community who need support. And specifically in the behavioral health integration department, we're very much connected to primary care so that we can provide destigmatized mental health services to patients in a timely manner rather than having them wait in the community.
That's remarkable. And I want to thank you all for that. I want to encourage folks to find these organizations online and reach out if you feel that you or someone you know could benefit from their services. I now want to launch into a conversation with you all about the state of mental health in our city right now. COVID-19 impacted our mental health in some expected and unexpected ways. My question is, what are the main mental health challenges you are seeing 2 years later from the date of the pandemic beginning? And how does your organization work with people facing those challenges? I'll begin first with Morgan.
A big mental health challenge that we've experienced within our community is loss and grief. There's been this collective trauma that I think many of us have experienced throughout COVID, and it's for us as providers to be able to provide support to folks. And when I say loss, not just loss of family members, but loss of identity, of jobs, economics, financials, loss of social connections, and just everyday routine and normalcy. It kind of threw people a little bit upside down. We've noticed an increase in anxiety and depression within the community. And what we've really done at NMIC to be able to support is we quickly adapted and transitioned into telemental health services to be able to decrease the barrier that it is for a lot of folks who might be essential workers, might work 2 jobs, might not have the access or accessibility to childcare to come into services. We offer really flexible scheduling virtually to really meet the client's need and support them with what they're going through.
Great. You said a lot of things that I wanted to touch on. For someone to qualify for telemental health services, what are the barriers and how can someone be able to schedule these telemental health services?
Definitely. Some barriers that we've experienced has been clinicians that provide services in the client's identified primary language, has been clients who might be uninsured or long wait lists. I think what we've experienced is it's so important right when you see a client with a need to support them at that time. It's when they're the most motivated and also the most in need. So if we kind of put them on a wait list and tell them we'll see them in a couple weeks or months, it's really hard to get those clients engaged. So for us to reduce those barriers, we have bilingual clinicians, we have flexible scheduling going from 9 to 5 and 9 to 9, I'm sorry. And we really try to offer the ability for clients to, even if they need to take a session with us and they're in their bathroom because they might have multiple family members in their household, they might be at a park, but we really try to encourage confidentiality and supporting clients so that they can attend the session. And we just are as flexible as possible.
Thank you, Morgan. And you also speak to, right, just loss more broadly in also including identity, which is not something I've traditionally been accustomed to thinking of loss. And so thank you for speaking to that. Actually, my office is currently working on legislation for grief counseling and understanding the reporting aspects of that. Particularly, there are a lot of young adults who are now becoming parents and caregivers and guardians because their parents passed away from COVID. We want to see that data, and so that our city can be responsive to those needs. That was an open-ended question. So if anybody else wants to talk about the unexpected challenges of mental health, I'm happy to hear about that as well.
If I could for one moment, another large component of the services we do, because we treat individuals with substance use disorders, is medication-assisted treatment. And as you can imagine, isolation for our clients is the exact enemy, and it's counterproductive to everything that they learn in their counseling sessions and how to cope and how to find sober social environments. So there were times where we had to deliver medication-assisted treatments to people's house. I know a lot of the other smaller organizations, it was a great point that Ms. Siegel pointed out, were not able to pivot quickly to telehealth or telephonic services. There was also a shortage of computers. Ordering, everything was backlogged. So there were some agencies that were not prepared to be able to make that transition. So not only did some of the staff not have cameras or the equipment on their computers, but the clients who are economically challenged, as I imagine everyone on this call's clients are, maybe didn't have phones or they didn't have access to devices. We had to, give some of our clients devices in order to be able to just do a telephone call.
And look, we have to, that's also, the onus is on city government to make sure that folks don't only have the devices they need to get the quality care that they need from providers like the ones we have here, but also we need to make sure we're expanding Wi-Fi as well, right? For low-income families that are economically challenged, as you say, Ms. McFarlane, so they obtain these services. So thank you for that addition. as well. Ms. Mariaschin, I don't know if you want to mention anything else to that question.
I was thinking about the school-based mental health programs and all the kids that were in school, whether or not they were with us. There was a lot of anxiety. There was a lot of anxiety going back to school once the pandemic started to normalize, so to speak. And we saw such a spike in referrals for patients who never had presented with anything before. And I always like to say that COVID didn't start any kind of mental health. It really just revealed stuff that was bubbling underneath. And in that way, almost it was a favor. It was a good thing because now we're able to identify, and there's such a focus and an emphasis on it. However, when that started, it did not feel like a favor at all. It was a little bit overwhelming, I think, to the therapist, but people really came together.
I want to add something here. So Morgan mentioned something earlier about an increased sense of anxiety and depression, and that's something that we're also seeing among our young students. One of the things we are very, very big supporters of are after-school programs, and also the community-based school model, which provides that mental health programming that we desperately need. When kids have after school, they're able to engage in more social isolation, and hopefully it can reduce the impacts, the mental health impacts that we have seen throughout this pandemic. So I just want to have some follow-up questions. What do you think typically gets left out of the mental health discussion that we need to talk more about?
So I think from the very beginning, the way that they do sex education in schools in New York City or anywhere, and some ideal ways that they do it, there's a lot of focus on prevention and education about what's positive and good behaviors as well, and health education. I don't think that mental health is a part of that. And so more, what's positive mental health, what's well-being, what are some warning signs, how do you handle it if a friend doesn't seem like they're doing so well or you're not? And really incorporating that into our systems would be great, just from the kid perspective. And then more programs like integration, where the primary care providers are talking about it, everyone's talking about it, we're talking about it right now, normalizing it. I think that's incredibly important. We should be doing more of that.
That sounds fantastic. And I agree, it should be treated with the same seriousness as other health education gets treated. So thank you for that. I'll actually take notes of that. And you're talking specifically mental health education within the school's curriculum, correct?
Schools, but also the education piece, yes, but also really embedding it into primary care practices. That's my bias because that's what I do every day. And I know at Ryan Health, we do a really good job of that, but really making sure that when your blood pressure is taken, when your A1C is taken, they're asking you about your depression, about your anxiety, about your stress, and it becomes a part of your understanding of yourself and not just something that's outside of you.
That's wonderful. And I would love to follow up with you on how that can be incorporated as well within primary care practice as well. And maybe you can give me some ideas on how we roll out a mental health education curriculum within the Board of Education. Does anyone else have anything else to add there, or?
I agree with everything that was said. And in addition to that, I think often once mental health is identified or diagnosed, we forget that we have to look at the social determinants of health. So there's all these other tertiary items that affect our mental health and our ability to cope, our housing instability, our physical health, as Ms. Mariaschin spoke of, lack of job opportunities, our education, fiscal stressors, all of those things affect our mental health, and it needs to be part of the conversation. Again, destigmatizing mental health issues.
It also helps, especially our students, be able to make sense about why they feel a certain way or why they're thinking certain things, right? And to be able to boil it down to these factors you mentioned, it also helps us really understand who we are and really, dig deep. And that's really what this is about. So I really appreciate that, that contribution. I have a question for you, Ms. McFarlane. I understand that Samaritan Daytop Village does work with substance use. There have been recent incidents involving folks facing substance use disorder. Could you speak to the need for psychiatric beds, but also, is this enough? What should our city's long-term strategy be to address folks exhibiting substance use disorders?
Yeah, so unfortunately, we were in the middle of the opioid epidemic when the pandemic occurred, which again, did not help our clients. When we speak to the need for beds, we're actually lucky when you look at the comparatively across the United States. New York does have a lot of services, but in the middle of the pandemic, what I found is that a lot of our primary care physicians, psychiatrists were called away, or they were doing services for hospitals, or they are no longer wanted to work in the field. And so we're struggling now to get workforce from social workers up. And I don't know if the other providers on the call are experiencing the same thing, but that was a huge problem we had. And I think that created a lack of access, coupled with us having to rework how we were able to admit clients into our program. So we were lucky. We have a longstanding partnership with an FQHC who was able to do rapid PCR and vaccinations for our clients and staff, but it made it hard to bring people in. We had to bring them in cohorts because we just didn't have enough space. And in the beginning of the pandemic, we weren't sure how to manage transmission. So that was another huge thing that we experienced.
Yeah, and in terms of long-term with substance use, I understand that Samaritan Daytop does transitional and permanent supportive housing. I actually visited the Young Mothers program in my district recently. Can you speak to the wraparound services and the comprehensive services that are done at these sites?
Again, at Samaritan, we believe that all treatment, mental health treatment, needs to be a holistic approach, meaning your treatment needs to include the social determinants of health and things that make long-term recovery, mental health recovery, as well as substance use treatment recovery possible. And that includes a plan from the city and the state that will give us access to more affordable and supportive housing.
My other question is for everyone watching, right? What can I do if I believe a friend or a family member is facing mental health challenges?
I can answer that. I think if you believe that a friend or family member is facing any mental health challenges, I think the first thing to do is listen and hear and just be with your loved one. I think education for yourself as well is really important before you meet with someone who might be struggling and telling them what to do. It's kind of collaborating and partnering with them to provide resources together. So in educating yourself, you might know what resources are available in the community, what might make sense to be able to provide to them. And then you might also allow them to kind of get on board and feel comfortable about reaching out for support. The other thing that I think we oftentimes don't talk about is if you do have a family member or loved one experiencing a mental health challenge, it might be helpful to get your own support so that you can talk through how you're feeling and what it's like for you while you're supporting someone else who needs help. So I think really using the whole family unit is really important in the treatment and care.
Thank you for that, Ms. Siegel. I don't know if anyone else wants to add to that.
Yeah, to a similar point, I think if you yourself have had any kind of therapy, it's helpful to bring it up because it normalizes it a whole bunch. And it's also okay if the family member or friend says, no, I don't want to talk about this. You don't want to push the issue. You want to listen and be there, be empathic no matter what, so that they can come back to you when the time is right.
That's great. And a question I also have is, how do we work to destigmatize, right? Really the seeking mental health services. I mean, you spoke to it, a bit, but I'm sure that there's a lot more work that needs to be done. I was diagnosed with ADHD and depression and anxiety. So when you mention these things, they really speak to things that I've lived. I also do therapy, but I think that we need to make others feel just as comfortable. And how do we do that?
Thank you for sharing that. That's really helpful to know.
We're trying to start the conversation, right?
Got to get that out there. It is really important, and this is going to sound like a real stickler thing, using person-centered language. It's very hard for all of us, but instead of saying, oh, they're bipolar, no, they are not bipolar. They have bipolar disorder. A person isn't homeless. They may be experiencing homelessness. We don't want to reduce people just to the elements of what they're going through at that time. And talking about it with respectful language really infuses respect into the dialogue. And also, again, from that systems approach, if we're talking about it the same as we're talking about diabetes or blood pressure, it's really creating a very level playing field for all of these things. And we want to make sure people understand this is serious. It needs to be taken care of, but it's okay. It's a normal part of your health.
That's a great way to think about how to address the destigmatization of mental health. So thank you for that. I have to ask, this is my last question. Where do you see government shortfalls on mental health services? What can we be doing more?
I was actually going to piggyback on your last question. I think it is important broadly that our legislators and government officials increase parity or equity in between mental health and substance use and physical health. And so there are often times that the services we provide may seem to be undervalued because they're not billed at the same rates. They're not advertised or marketed the same way you may market that it is important to watch your weight and get physicals. So it further creates the stigmatism for those that are mentally ill. And so they're afraid to speak of it, whereas people would not be afraid to say, I have diabetes, or they're afraid to say, I have relapsed, where you might not be afraid to say, I had chocolate cake this weekend, even though I have diabetes. And so encouraging the conversations, but also getting support from our legislation to make sure that there is equality and parity amongst physical health and behavioral health.
What I'll add to is I think the importance of government putting in time, resources, and funding into the supports for mental health. I think the ability to destigmatize mental health and also provide the funding for programs that are typically underfunded will really help to open up access to services for our community.
That's great. I have a question. What is your, you may not have them, but what is your favorite success story that you've witnessed in terms of prioritizing mental health?
I can share from the NMIC standpoint. For us, it's so important to have all of our staff members really engaging in the mental health work. So if you're a paralegal, a case manager, academic and career counselor, if you're the chief of staff, it really doesn't matter. Making the conversations okay to talk about and comfortable for our staff members. So our success has been supporting staff to be able to do assessments for mental health and referrals for mental health. It's the only way that by getting in everyday and conversations and interactions, by getting everyone involved is the only way that we can provide access to everyone that's in need.
That's great. Anyone else share a success story?
On a systems level, I think it was a couple years ago, we were all talking about how not everybody knew from top to bottom how to handle patients in a waiting room. You don't handle patients, you work with them. So we implemented a training program for all staff, and then we infused it into the orientation, not only on crisis de-escalation, but on appropriate interactions and identification of patients who might need more support. And to do that was a big lift, but now it's just a part of our day-to-day, and it's been very rewarding. Thank you.
And Ms. McFarlane, I know that you have a lot of success stories as well, I'm sure. So if you could speak to one.
I think it is important that we, as everyone else has said, kind of infuse the ability to work with our clients and meet our clients where they are and give person-centered treatment. So in all of our transitional housing, which are DHS funded shelters, we call them transitional housing. We do families and singles. All of our staff are trained in trauma-informed care. And we are in the process of making sure that our environments alone are trauma-informed and are respectful of where our clients come from. And some of them can be coming straight out of incarceration, and the intercom in the building is traumatizing. So just making sure that we're aware of that and meeting the clients where they are.
How can the audience get connected with each organization? If you could answer really quickly.
Call, come in, check out our website, ryanhealth.org. We want you here.
Website, and we also have an intake line, a number that they can call to get connected to different services that they might be looking for.
Samaritan as well, www.samaritanvillage.org.
So unfortunately, it's time for us to wrap up. This has been a very informative discussion. I want to thank my guests today, Alicia McFarlane, Morgan Siegel, and Jenny Mariaschin. On behalf of all the residents of New York City, we greatly appreciate your time, your insight, and dedication. I want to thank you for watching Represent NYC on the Manhattan Neighborhood Network. Goodbye.